So without any further ado, I will introduce the lovely Laura Nyblade, who's giving up her evening to be with us today. I'm going to be placing into the chat some of Laura's papers because her body of work here is phenomenal and really inspiring. So as Laura gets started, I'm going to first place in a paper that she wrote for The Lancet about HIV stigma and the 2030 goals. And to me, that was fantastically capturing all that we know, all that we need to know, and what else needs to be done to tackle the insidious corrosive effects of HIV stigma if we are to meet the 2030 goals. So you have Laura's bio in the invite for this. I'm not going to go over that because it's long and extensive, and we need to get into the guts of our discussion today. So I'm going to hand over to Laura, make sure the slide sharing's still working, and let you go. So welcome, Laura. Thank you very much for being part of our discussions in our Spotlight on Stigma series. Over to you.
Okay, thank you so much. Let me just get this going and you can tell me if it's there. Can you see my screen?
Yes, all great.
Okay. So good morning or good evening, as is in my case. It's very much of an honor to be with you today to share work that has built on the collective effort of many people around the globe. So I want to start by saying the work I'm presenting today is really the collective learning and knowledge of many, many people in many regions of the world. Just by way of introduction, I'm based at the Research Triangle Institute, RTI International, but I sit in the Washington, D.C. office, but we're headquartered in North Carolina. RTI is a nonprofit research institute. As I said, it's based in North Carolina. We were started about 60 years ago now by 3 of the universities in North Carolina in what's called the Research Triangle Park. We are a nonprofit, independent research organization, nonpartisan, that does a lot of different things, a lot of different areas of research, both here in the US and globally. So if you're interested in learning more, look us up. So with that, I'm going to start my presentation. And so I think you're all here because you understand the importance of tackling stigma. And I often like to start my talks with this quote from Justice Cameron from the Constitutional Court in South Africa. So why focus on tackling stigma? Well, at the heart, it's a fundamental human rights issue or imperative. But as Justice Cameron noted so succinctly, speaking here in the case of HIV, but I think this is equally applicable in many other health and social areas where stigma and discrimination are rife, is that if we don't appreciate the nature and impact of stigma, none of our interventions can begin to be successful. However, having noted that, I think the real question is, what are we going to do about it? So in response to that, I'm going to start today by sharing some of the key principles for stigma reduction that have emerged from the past 2 decades of stigma reduction programming and research. Principles that we have learned apply across very different contexts, whether those differences be geographical, sociocultural, or the actual health system, and that they apply as well for interventions with different groups. For example, the general community, health workers, teachers, or others. But I'm going to focus specifically on the health facility setting, and I'm going to turn to one example of how we've applied these principles for HIV stigma reduction, and then talk about 2 additional examples of how we built on that work to address additional, I guess you could say in a sense, HIV adjacent or intersectional stigmas in health facilities. So I'm going to start with what I call key principles for reducing HIV stigma. These aren't in any particular order or of importance, and they're all interconnected. So let me start with the light blue bubble. We've learned over the past 20 years of research and program implementation that we need to focus on the drivers of stigma, the things that are causing the stigma, but in particular, 4 that we have very deliberately labeled immediately actionable. Why that immediately actionable? Well, stigma, because it's a fundamental human process that is all around us and that we all engage in, can be overwhelming to think about and act on. So much so that it can lead to inaction. So I often get this sort of look on people's face of fright when I start talking about stigma, because it's sort of one of those things you don't want to deal with because it feels so overwhelming and so large. So one of our key lessons learned in the past 2 decades is that it's critical to focus first on the levers or the drivers of change that we can get a hold of right now and shift right away, while we work towards that longer term social change that is our ultimate destination, to have a truly stigma-free world that upholds all people's human rights. And the good news is there are actionable drivers, and that when addressed do lead to change, and change that is visible pretty quickly, which is really important for keeping the momentum going and being able to keep moving forward towards that larger social change. So these are the 4 that we've pulled out from our work over the past 2 decades that we find are really important. The first is awareness, which is simply about building awareness of what stigma is in concrete terms. We all stigmatize often and without realizing that we're doing it. It's not because we intend to harm often, but because we simply do not recognize that we are stigmatizing. For example, we are unaware of how stigma appears in the language we use in our daily, often routine interactions with others. Something as simple as creating awareness of what stigma looks like in concrete terms can bring about change. We see this all the time in health facilities. The next actionable driver is fear. Whether it's fear of acquiring HIV in ways that HIV cannot be transmitted, and that fear still exists, including in health facilities in many places around the globe. It's in places where I work, it's really still very, very present. And that leads directly to stigmatizing avoidance behaviors that mark a person as different and as dangerous. Or it could be the fear that we might be labeled as one of them because we're providing non-stigmatizing care to a stigmatized person or group. The third is our attitudes and beliefs. For example, while we do our best not to bring our personal beliefs and attitudes into our work and research, sometimes they can unconsciously influence the way in which we deliver care or design and implement research, or simply in our daily interactions with other people. Understanding and acknowledging those attitudes and beliefs, recognizing how they might show up in the way we do our work, whether that's service delivery or research or some other kind of work, or how we interact with research respondents or clients, can help us deliver stigma-free services and research. Lastly, when we're working in institutions, whether they be health delivery ones, schools, places, or even places of worship or other types of institutions, the institutional environment is an important driver of stigma and or of how we reduce stigma. And all of these drivers are actionable now. So really, we're finding no matter what environment we're working in or what area we're focusing in, those key drivers, those actionable drivers that you can get a hold of now are really important to take hold of and start moving. So in addition to addressing those, there are 2 other key principles for stigma reduction that have emerged from all this work that's been done globally. We know that the HIV response will only be successful if communities are at the table and leading. Successful stigma reduction interventions must center those experiencing stigma at the core of the response, building from a strengths-based perspective and ensuring people with lived experience are at the forefront of designing and leading the response. However, also ensuring that people with the lived experiences have the resources needed to do this safely. And you'll see, and I'll talk a little bit about a program in Ghana and the challenges there around safety. So some ways to do this are through supporting networks, empowering and strengthening capacity, and recognizing and addressing internalized or self-stigma. Next, we've learned about the importance of engaging those with power, the opinion leaders, those in society with the power to shape our behaviors and begin building partnerships between people or groups with power and the groups experiencing stigma who often do not have power, by definition, do not have power. And we know, not just for HIV, that contact strategies are one of the most effective ways to reduce stigma. When we get to know each other, when we break down that us versus them, the othering step in the process of stigma becomes very difficult to stigmatize or discriminate. We also know it's important to model desirable behaviors. Telling people what not to do is often not effective, while showing what we should do has much more traction. And then recognize and rewarding those who are modeling the desired behaviors, say the stigma-free behavior. I just want to share an example from many years ago from work we did in a small grants program in India, which funded groups to develop their own stigma reduction interventions. And then a collective of sex workers had one of these grants. And so they started by building agency within and among their own members. So really working to build self-esteem and skills for interacting with people in power. And then they kicked off their external stigma reduction intervention by delivering roses to all of the doctors who had treated them with respect at the local hospital that they had to use. And this set off a buzz in the hospital. Why were these doctors getting roses? And so this led to discussion and eventually to a partnership between the hospital and the collective to address stigma. So just to give you three key principles for thinking about as you're developing or thinking about stigma reduction. And now I'm going to turn to some specific examples of how we've applied these principles to tackling stigma in health facilities through an approach that recognizes at its core that everyone, that is all staff at a health facility, whatever their role, whether it's clinical or non-clinical, have a role to play in reducing stigma and creating an environment that focuses on the client and is really, in other words, person-centered care focused. So call it the original total facility approach, was developed under the Health Policy Plus project, which was funded by PEPFAR, which is a sort of the US government foreign aid focus on HIV through the US Agency for International Development. So we had funding through PEPFAR and USAID to develop this total facility approach. And we developed it and conducted preliminary testing in Ghana and Tanzania with a focus primarily on HIV stigma. Since then, we have further adapted and tested this approach, again in Ghana and Tanzania, to focus more on key population stigma. And it's those adaptations that I'll focus on more in depth in this presentation. But before I do that, I want to share just a bit about the foundations of the original TFA approach, which runs through these adaptations that I'm going to share. So as originally implemented, the total facility approach had 3 steps that focus basically on 3 socioecological levels within the facility. So we often think about the facility as one of a socioecological level, but we sort of think about the facility as having kind of these different levels. And so we had an approach that sort of looked at these different levels and trying to tailor the interventions that we developed for this total facility approach to encompass all of those levels. And this 3-step process, the first was formative research with the facilities and clients of the facility. In the case of the original TFA, that was survey data. And I'll talk about the adaptations we've done, where we've done a lot of qualitative data to help us figure out where the gaps are in the particular stigmas that we're focusing on. So this initial focus on data, and it can be very brief, but it really serves dual purposes. In this case, it was as a baseline for the evaluation, but also as a catalyst for discussions with the facilities about the need for action on stigma in their facilities. We often hear from facility management, oh, we don't have any stigma and discrimination here. Facility down the way, yeah, they have problems, but not us. So we say, great, let us measure that. Let us show that. And then the data then helps us really then catalyze or notice the need for action with management, and then helps think about what that action might look like. So for example, in the original TFA, we took the data back to the intervention facilities, sort of some simple sort of frequencies of what was going on, and then through a participatory dissemination process, had facility management and staff working in small groups, analyze the data we had just a few simple guiding questions, and that really sparked some discussions about like, oh, wow, this really is going on in our facility, and then thinking about how to respond to what the data was saying. And often, always actually, one of the key responses that comes out of these sessions is the need for staff training. So this leads to our second step, which is really building capacity within the facilities and among clients to actually deliver the intervention in the facilities. So the intervention is delivered from within the facilities, not by outsiders. So there is a sort of a set of participatory tools that were developed back in the early 2000s that we've adapted and implemented in countries across many regions of the world. That was really the basis for these training tools. And I'll show you a little bit about what the curriculum looks like. But so you have this training piece, and I want to note that it's, as I said, delivered by staff and clients who are trained together to be training teams, and they then train all of the staff in their facility. And we train all different levels of staff together. So there's no hierarchy in the training. And when we started out, we were told you can't do that. You can't train doctors with cleaners, but actually you can, and it works really well. And it has some really interesting benefits to staff morale and changing the way staff work together. And then the third piece is really thinking about then once you've done all this training and staff have an understanding of stigma, then what do you do next? How do you integrate that into your facility structures and processes? And we did this in different ways. Obviously, management is very important. So there was continuous engagement and involvement of management across the process. But then we had creation and sort of official sanctioning of stigma reduction champion teams, which were often led by the trainers. But often people from the training kind of emerged organically who wanted to do more. And they designed and then implemented additional stuff, most of it that didn't cost anything. So thinking about ways that you could leverage what was going on already in the facility. But we did give small grants to kick that off to each of the facilities. So I'm going to turn to two specific examples of how we've adapted and implemented the TFA to provide a better idea of how it works, starting with an example of how we've adapted it to address intersectional stigma in Ghana, specifically HIV sexual and gender nonconformity stigma faced by men as part of a multi-level intervention. And then if I have time, I can also share an example from Tanzania. But just a couple things I want to highlight and reinforce about the total facility approach, thinking about those principles I talked about. One is that it creates new opportunities for contact outside the provider-client power relationship. This is both because we train staff and clients to deliver the training together, but the training also has involvement of clients through a panel that is always very powerful. It's modular, so it's very flexible in implementation, and the way it's delivered gives minimal service delivery disruption. So, and I can talk more about that in the Q&A if people are interested. So just wanted to highlight those things. So this is a study I'm going to share just a little bit about how we adapted it. But before I do that, I want to talk a little bit about terminology and positionality and explain our use of the term men who have sex with men, or the acronym MSM, in this study. As many of you know, there's a variety of terms that have been used to describe men who have a range of same-gender experiences, including same-gender sex, desires, relationships, and identities. These terms, such as gay, bisexual, queer, and same-gender loving, as some, have specific socio-political and cultural meanings for the groups that identify with them. Since the onset of the HIV pandemic, the term men who have sex with men, the acronym MSM, has been broadly applied to men across the range of same-gender sexual experiences. MSM is an epidemiological term used in public health surveillance in the taxonomy of HIV exposure categories, such as perinatal or injection drug use exposures. The term MSM does not refer to sexuality and include, for example, a heterosexual man who has been exposed to HIV through a non-consensual sexual encounter with another man. Over time, the use of MSM has crept beyond its original intention and is now popularly used as a convenient, blunt shorthand reference to gay or bisexual. The continued consolidation of men with diverse same-gender sexual experiences into a single yet epidemiologically precise term such as MSM erases important lived social realities of the men who are taxonomized into one group. As a multicultural, our team is Ghanaian, Korean, and American team led by Americans who are conducting US government-sponsored research in Ghana. So we are funded by the National Institutes of Health in the US to conduct this research. We also acknowledge the settler colonial history of taxonomizing humans in Africa, Asia, the Americas, and elsewhere into groups in order to render them and their sociocultural practices more interpretable and manageable to individuals viewing and administering them through a Western intellectual lens. So in this presentation, except when making references to specific sexual identity groups, we use MSM to refer to the men who were recruited in a larger HIV prevention trial based solely on their self-reported potential HIV risk exposure category classification, not on their sexualities. So this study that I'm going to present on how we adapted this TFA is a partnership between 7 research groups, 4 in Ghana, including 2 that are community-led by men and provide services to men. We have 8 hospital partners who we do not name here, given the ongoing political and social challenges around a bill introduced to Parliament just as this study was started 4 years ago to further criminalize people in same-sex relationships as well as those who provide services to them. So this is this is a challenging time in Ghana and in many countries around the world. And so we have to think about safety. So that's why the hospitals are not mentioned here. So I'm going to just give you an overview of the study's design so you can see how, when I talk about the TFA in particular, how it sort of fits into the larger study. So we set out, this is a multi-level study, and we set out to address stigma at 3 levels: the interpersonal or individual level, so that's individual men; the interpersonal, sort of within networks of men, so groups of men; and at the organizational level, which is within health facilities. That's where we specifically adapted the TFA, and I'm going to focus on. We worked to create connections between the 3 levels as we adapted and implemented these interventions. So I'm going to talk briefly about all 3 interventions so you can see sort of how they fit together. I'm not going to share specific study aims or our RCT design, but happy to talk about that another time or take questions at the end. So as I said, we have 3 levels of interventions, and I'm just going to quickly run through them and then focus more on how we adapted the TFA. So to start, we have what we call Nyansapo, which is adapted from 3MV, which is a US Centers for Disease Control designated best evidence intervention, which demonstrated several improved HIV prevention behaviors among men in the US. It was designed to address behavioral and social determinants of HIV risk and has been previously to this study implemented in Ghana, or adapted to be implemented in Ghana, and called Nyansapo. So that's where the name comes from. For the PRISM study, we made some adaptations to Nyansapo to address intersectional stigma more specifically. And so, the focus being HIV, same-sex, and gender nonconformity stigmas amongst communities of men. So just to give you some examples of some of the adaptations we made to it, one was to add more focus on gender diversity, which included incorporating a genderbread person exercise, which some of you may be familiar with, which explains human sexual and gender diversity. And then as part of creating connections with the health facility level intervention, we incorporated local nurses from the intervention facilities into the delivery of Nyansapo, and they focused on particular exercises, but also participated in all of the full like 2.5-day convening, which I'll talk about shortly. So this really helped to build more trust in healthcare providers, to start building trust in some cases, because it can be very broken. We also added more content to address internalized stigma. It was implemented in a residential format. So this was a group intervention. So the men were taken out of their usual environments for convening in groups of 20 or less for 2.5 days. And in those 2.5 days, they engaged in intensive and interactive activities focused on intersectional stigma and HIV prevention. We had over 95% of the men who enrolled in the study complete Nyansapo. And when it was originally, the original 3MV in the States was delivered in 7 weekly sessions. And we have found in Ghana that it's better to have a residential. And because of that, we think we had a much higher completion rate than the original 3MV in the US. At the individual level with men, we implemented what we call Hive-3, which is HIV empowerment, education, and empathy intervention, which is based on the dentist peer support. It identifies 3 kinds of support: informational, emotional, and affirmational, and it's delivered by peer mentors whose role is to nurture resilience and help mitigate the effects of intersectional stigma, including internalization of that stigma. We did do some interventions to the original Hive-3. So, for example, Nyansapo facilitators served as the peer mentors, and that helped to maintain continuity of the emotional connections, which were gained at the Nyansapo residency, and also then to help reduce social isolation. We enhanced the peer mentor training to include more focus on intersectional stigma experienced by men at multiple levels. And for example, we incorporated role plays as a way to sort of build the peers' ability to sort of provide support around intersectional stigma. It was implemented by 4 peer, in the PRISM study, it was implemented by 4 peer mentors in each of our 2 sites, so 8 peer mentors in total. We had 2 sites in Ghana, 1 in the Ashanti region and 1 in the Greater Accra region. And again, they provided these kinds of 3 supports that I talked about, and they used a standardized peer support protocol, which allowed them to meet peers anonymously. So this was an in-reach model. That is, the mentors never reached out to the men, only responded when men reached out to them. So we gave the men mobile phones with registered SIM cards, both for to ensure there was privacy and safety, and then to allow for the interaction between peers and the men. So now I'm going to turn to how we adapted the HP Plus total facility approach. I'm not going to talk about this slide because I already shared some information on that. So I'm going to jump right into how we adapted it. So the adaptations for all 3 levels of this intervention were informed by formative research. So we conducted focus group discussions and in-depth interviews with men and with health facility staff, that is both clinical and non-clinical staff. And the initial adaptation was done based on a rapid analysis of this data, and then in consultation with a broad range of stakeholders and through a stakeholder input process over time. But 2 key areas that emerged from the formative research as critical gaps in the existing training curriculum for health facilities in our focus on addressing intersectional stigma faced by men was gender and mental health, that is, misconceptions around mental health and men who have sex with men. So, in talking about the importance of addressing awareness, we had health providers telling us, we don't stigmatize or discriminate. We give the best care possible. As soon as someone comes in and we know that they're having, it's a man who's having sex with other men, we immediately take them to the psychiatric department. So they get the best care. So there were a lot of misconceptions around mental health and men who have sex with men. So in response, we created 2 new exercises seeking to address gender more deeply, and then these misconceptions around mental health. So part of our adaptation was creating 2 whole new participatory exercises to fill these gaps that we had identified from the formative research. And in addition to that, we also incorporated specific stigma manifestations that had come up in the data into the existing exercises, and also expanded some of the activities that still worked to include more focus on intersectional stigma by creating new pictures, developing new case studies, and role plays. So if you'd like to learn more about the adaptation process, we published an article in JIAS on this last year, so you can get more detail about that. So how did we implement it? So we implemented the TFA in the PRISM study following the original HP Plus process. So as you remember, I presented that a little bit earlier. So we started with the training of trainers. We have some fabulous master trainers based out of Zambia, but we also have some in Southeast Asia. So they came in and they trained teams from all of the intervention facilities. So each facility had 3 healthcare staff and 1 community member to form a team. And they were trained together in a 5-day training, both in participatory methods, which is often new. So how to use and train using those methods, as well as the curriculum content. After that training, they also received on-site coaching for the first round of training they delivered to health facility staff, and then ongoing support as needed. The second step was then for those teams to deliver that training to their facilities. So they trained their peers, both clinical and non-clinical staff, in a 2-day on-site training on the content they learned. So in Ghana, because these were big facilities, they chose to do it in 2 consecutive days because they could pull staff from different departments. Because we're taking staff from different departments and staff from all different levels, you can, it takes a bit of organization, but you can organize it in a way that you have minimal disruption to service delivery. In places where you aren't in large facilities, like the example in Tanzania, which I think we probably won't get to given the time, but we actually worked with management and staff to decide how they wanted the training, and they chose 5 sessions after work over a period of 2 weeks. And I thought, wow, this is never going to work. But we had close to 75% who attended all 5 sessions, and over 90% who attended 4+ sessions. So it's to say that this training is very flexible and modular in way. And then the last piece was supporting champion teams in the facilities. So these are teams that are sort of supported and codified by management. They develop an action plan, they build on ideas that are generated in the training, and they get a little bit of seed money to actually kick these off and keep them going. So this is what the sort of a summary of what the participatory training curriculum looks like. And you can see through this some of those actionable drivers that I talked about. So we have a lot that works on creating awareness. We have exercises that address fear. Confidentiality is a big issue. So we have a specific exercise on confidentiality. And then we have focus on gender and sexual diversity and human rights. And then we do a lot of work around building empathy and reducing that distance, that us and them, that is such a big part of the stigmatizing process. And then working to create change. So at the end of this training, and actually throughout all the exercises, we have people thinking about, what can I do to change as an individual? What do I have power over as an individual? And what do we need to do collectively as an institution and beyond the institution to change this? And as I mentioned, this is modular, so it can be delivered in lots of different ways. And then just to give you an example of some of the activities that the hospitals themselves came up with and implemented, Most of the hospitals wanted to really announce publicly that they were doing something about stigma, but then also to have some accountability for it. So they put up or reinvigorated complaint boxes or set up phone systems for people to call, and did a lot of announcement of that. But also thinking about things like integrating how they could integrate stigma reduction into existing structures and processing. So for example, on onboarding of new staff, in refresher exercises and staff meetings, in ward rounds. Some places decided they wanted to have name tags so that clients would actually know the names of the people who were working in the facility, so that if they did have a complaint or a compliment, they would actually know who it was. So different things that the different facilities have come up with. So I think just quickly, I'll just mention in Tanzania, we've been working on something that is adapting this to address drug use stigma in HIV treatment clinics, which is a big issue. Again, this work, I want to acknowledge all of the people who make this possible, the study participants, the implementing team. This is again funded by NIH. And, we just it's a small study. We're adapting just the curriculum part of the TFA at this point to address drug use stigma in these HIV care and treatment clinics. And then we were piloting it for feasibility and acceptability. Just to give a sense about how we adapted it, very similar to what we did in Ghana. We had formative research that helped us figure out what it was we were missing, or how to adapt the things that were in the curriculum that still worked. So we are also very lucky in Tanzania to have a team of master trainers who've been doing stigma reduction for 20 years. So they really led this. We had a stakeholder adaptation workshop, and then more revisions, external review by experts externally, et cetera. And then now we're actually doing another round of revisions based on the experience of the actual implementation of the small study. So this is a really busy slide, but again, these are kind of the sort of the threads of creating awareness, addressing fear, working on those beliefs and stereotypes, and then providing some actual knowledge, in this case around understanding drug use as a medical condition, not a moral failing, and then working to create change. So very similar to what we do in Ghana. So I'll just end by saying, we can act on stigma, and it's possible at every single level. And I think there's a lot of synergies that we can work on, because, there's HIV stigma, there's stigma against, lots of other stigmas. So thinking about it, how we can leverage those synergies. And just to say, if you invest in stigma, that's a really good investment, because at HIV, it pays off across the whole prevention to treatment cascade. And then just to end by saying, you all have power to address stigma. So how are you going to use your power?
Brilliant, Laura. Thank you very much. What a really full look at complicated, complex interventions in Ghana. And we've got 20 minutes or so left in our session. I've just put into the chat, for those who weren't with us at the start, that Nikki Bath isn't able to join us today and sends her sincere apologies for that, dealing with a family issue at the moment. And I've put in the chat the kinds of questions we were going to ask Nikki to consider in relation to Laura's presentation. So invite you all, particularly people with lived and living experience, about commenting on the questions I've put in the chat, or other issues, particularly around the total facility approach, to raise your hand, put your camera on, whatever you're comfortable with, and join in. So Laura, total facility approach, as you mentioned, from the cleaner to the management, to the clinical staff, to the front desk staff, how does that, what's the vibe like? How do people like being in training sessions with people that they might not professionally work with, but are absolutely part of the unit of care?
Yeah. So, like I think I mentioned when we started out, and I said, we're going to train everybody together. People were like, you can't do that, you know? And so this is going to sound really hokey, but it works really well. So we start our training. Well, first of all, it's working with management to schedule this and explain that, we are going to do this. We are going to train people from different levels together. And we start, it's really about creating the atmosphere or the safety of the room. So one of the things especially my colleagues in Tanzania like to do is they have everyone create these paper hats, and you write all of your identities on your paper hats. So, I'm a mother, I'm a doctor, I'm a friend or whatever. Like they all go on the hat. And so we have a discussion about that. And then it's like, okay, now take your hats off and put them in the corner. When you're in this room, your identities are important, but when you're in this room, they're all in that corner and everyone is on a first name basis.
Great.
And when you leave the room, you can put your hat back on. But in this room, and so it's interesting to watch because at least in the context that I work in, someone who's a security guard would never address a doctor by a first name, right? So it takes a little bit to get over that, but then it's like it, and everything's very participatory and whatever. So it's about building that vibe. And one of the and there's so many stories that kind of just warm my heart from this. But in one rural hospital in Tanzania, I had the guard say to me, well, first of all, I never understood that I had a role to play in people's healthcare. Right. And no one's ever recognized that I have a role to play and that I'm important. But the second thing is, I've never felt comfortable or been able to talk to the doctors. And now when I see them leaving at the end of the day, I can see on their face if they've had a hard day, like maybe someone's died, and I can talk to them and comfort them,
Right.
which I was never able to do before.
Yeah. You're humanizing the other staff as well as the people who use the service as clients or consumers. Yeah.
And management has afterwards, because they're always a little bit resistant to this, that's sort of been the main take home from management is that, wow, this has really changed the way our staff interact with each other. And it's led to better service for all of our clients, not just our clients who are living with HIV or who, are people who use drugs. And the other thing is, I don't know in the Australian setting, but in the settings that I work in, there are a lot of staff who are living with HIV or who have family members who are living with HIV, and they've, never been able, they themselves experience a lot of stigma and discrimination. So it's also about recognizing that, we're the intervention is also doing something for staff in that respect, I guess is what I'm trying to say.
Yeah. The benefits ripple out into other areas of operations, and not just, here's the stigma intervention doing stigma things. It's actually building connections, quality across the service.
Yeah, and I just got back from Ghana where we disseminated the results of the trial, which were very positive. And I got and I had previous to that been able had a recent trip to meet with the trainers at the facilities, that both the community trainers and the health facility, and they talked a lot about how being trainer completely changed them. And how much it was capacity building for them. Like they had never before would have gotten up and talked in front of a group, for example, or would never have challenged or pushed back at a superior in the health facility when they saw something happening that was wrong.
Great. We've got a couple of questions coming in, and Lauren, I wonder if you feel like turning your camera on and asking your question.
Carla, I'm not going to turn my camera on because I'm still sick. So I'm actually like a gastric bug. So I'm actually still in my pajamas in bed. So I'm definitely not putting my camera on. But Laura, thank you so much for that wonderful presentation. It was really interesting. I guess the So a lot of work that we've been doing has been with hepatitis B, and it's qualitative research. And one of the things we're finding is that stigma and discrimination is understood differently amongst these culturally and linguistically diverse communities. And in fact, in some instances, hepatitis B, as an example, is not stigmatized or may not be viewed as negatively within their culture, within their home context. And then it seems to be that when they come into Australia, this kind of stigma is imposed onto these diseases. And we still, again, are trying to grapple with the information that we're getting because it's done in language by people of the same ethnic background. But it is leading me to wonder, I guess, what happens in instances where we are actually imposing the stigma, and how do we work within medical frameworks or health contexts where our health context is actually the context that's creating the stigma?
Yeah, well, I guess you've taken the first step by recognizing that that it is the health context that's creating that stigma. So can I ask, it's when people with hepatitis are interacting with the health system that they start feeling stigma, or stigma?
As a kind of general example, one of the things that one of the participants was saying is that in their home country, it was just understood as a liver disease and one of a variety of liver diseases. But then coming into Australia, they get told it's hepatitis B, and a lot of, then stigma is associated with that hepatitis B. So within the Australian communities, or for example, they're told not to share cutlery, or they're not told by the health system, but peers don't want to share cutlery, don't want to sit close to them, and they never had those experiences.
You've just bumped your mute button, Laura.
Sorry, that's exactly the reason that I didn't want to turn my camera on. So I know it's probably a little bit hard to explain because my head's fuzzy, but also because we ourselves are trying to understand what these issues may be in terms of the way we look at the data that we're getting.
Yeah, and I think it's so interesting. I think it sort of also speaks to the power of language and how we frame things. So, in a lot of the contexts I work in, HIV has been a really vertical program, and you'll walk into a facility and, the HIV clinic is, well, first of all, it's often separated from the rest of the facility, often close to the morgue. And it's got a big label on it, right? And it's like this frightening separate thing, rather than being like, this now HIV being more of a chronic disease. So actually, one of the hospitals that we worked in, they actually worked to move their HIV clinic away from like an HIV clinic to integrating it into their chronic disease care clinic, so that there would not be so obvious. And I guess that thought is just triggered by you saying, in other places, it was just a liver disease. Like there was nothing special about it. It was just a liver disease. And then when you come to Australia, it's a special liver disease in a different way. So I don't know if that's helpful or not, but just in sort of the messaging or in how we think about it. And obviously it's got to go out to the community.
That's great. Thanks, Laura. I guess the thing that struck me about it is that sometimes even when we are sensitive to stigma, we're still sensitive to it within our own understandings, which is exactly what you started your presentation about. So it's important to understand that other groups may understand all of these issues completely differently, I guess.
Yeah. So understand things and stigmatize things differently. One thing we have learned, which is kind of counterintuitive, is that yes, stigma is can be very culturally specific and driven, but the actual stigma process is very fundamental at its core. And I think that's what gives me hope that we can actually scale up stigma reduction. So I think, we wrote a paper a long time ago about it being common at its core, and the differences are more of like nuance than like the center part of it, because stigma is such a human social process. But what we apply stigma to, or where we engage that process, is different, as you've just explained around this.
Yeah, thank you. That's great info.
Thanks, Lauren. And Laura, I can see Megan Brooks from Southwest Sydney having training envy, because Megan, do you want to turn your camera on or your audio on and explain what situation you're working with? Okay, not sure if Megan's there, but Megan in Southwest Sydney used to run a one-day intro to bloodborne virus workshop and was growing well evaluated, great exercises, harder to get time now, so redeveloping those as webinars. So to have the Megan's not sure how to turn a mic and camera on. There we are.
I wasn't in full screen, so yeah, sorry. Oh, look, I think probably quite a lot of the LHD's HARP units have done things like this over the years. And yeah, I just wanted to sort of say that, yeah, the idea of having health workers from across the whole hierarchy of the health system in one room is actually a really great thing. And it always surprised me that doctors came. Like, you think, why would a doctor come to an introductory sort of session on bloodborne viruses? But I guess maybe some doctors don't do a lot of that in their medical training. I really don't know. It was mostly nurses that would attend, but a lot of, cleaning staff and, people from across the whole spectrum, and it was self-selected. They weren't compelled to come. So it was always really interesting. The other thing that I liked about it is I felt like it was a way of smoking out our support network in a way. So to some extent, you're preaching to the converted, I suppose. Although it was always obvious that people would shift along the spectrum in terms of their values and understanding. But it starts to form your network of allies as well to run courses like that. And it's a bit like painting the harbour bridge. You've just got to keep doing it because the workforce is constantly turning over.
Mm-hmm. Yeah, thanks for that. Yes, and I think it's interesting. I saw your comment about it's harder to get people into in-person trainings, and it's interesting. I wonder if that's going to shift at all, because I think at least I'm very tired of Zoom trainings, and we found actually that people are quite hungry for the being in person, because at least here in the US now, like I come to the office every day and there may be 4 or 5 other people in an office that used to hold 200. And so I think, so it'll be interesting to see. We've been having a discussion and a debate about like how much can you really reduce stigma through online courses or remotely, because to really change something so deep, I think the human connection and the learning in groups and the support as you struggle through that, because the stigma reduction training really does ask you to do quite a bit of reflection on things that you might not want to reflect on, is really important. So it's interesting to me. I was part of a study in India where we did kind of a hybrid model, and we published that as well, in Frontiers Public Health, I think. But we addressed actually the fear-driven parts of the HIV stigma through online, and also the sort of starting to create awareness of stigma. And then we kind of hit the other pieces in an in-person session. But it is, and health workers are very busy, so it's very hard, to think about this in sustainability going forward. So, we don't have all the answers. We're still learning and growing. But yeah, I see a comment from Joseph. Including community groups in the development of training and being invited as guests is essential as well. I agree. The having the joint training teams of healthcare workers and community members is really central to this approach and very important. And then there's a panel that is always part of this, which is we do it as kind of like a talk show, but it always happens towards the end of the training. And it's we allow health workers to like give us questions anonymously, which we then filter and reshape because sometimes we get inappropriate questions, and those are given to the panel ahead of time to think about which ones they'd like to answer, and then we run it kind of that way. But then if the panel is comfortable, we actually open up to take questions directly and then have them stay afterwards to interact. In our cases in sort of Ghana and Tanzania, health workers will say, this is one of the first times I've ever met a man who has sex with men, which is not true, but the first time. So that's, thank you for that. Very important.
So Peaches, I can see your hand. We've got 2 minutes left. Over to you.
Hi, I'm Peaches. I'm currently working with WorkSafe Victoria, but my background is really in sex worker peer organisations. And so I've done a lot of that sort of stigma training and that sort of thing with healthcare workers and all kinds of different services. But I think for peer workers themselves, there's, a huge part of that role is helping people in community to navigate these really complex systems. And so I suppose my question is about, did you find that there were benefits as far as that kind of mutual learning process for peer workers, as far as having better understanding of the healthcare system and how to navigate that so that they can kind of pass that knowledge through their communities as well? Was there any kind of sort of benefits that you saw with that, or?
Yeah, and so I think you're speaking to the multi-level piece, which I think is very important. So, we had the multiple levels and then there were the connections, right? So a lot of the a lot of the men who became our community trainers also then became trainers for the Nyansapo, which is the peer. But when we also had our nurses, not always nurses who were trained to deliver the intervention, but nurses from the facility who then became part of the group intervention. So they really helped to start creating trust with the health system, because in Ghana, the trust is really broken for men from sexual and gender minorities. And so that really helped. And then I guess we haven't published our results yet, but one of the interesting things that happened was we tried to randomize men to like treatment and control arm. Everyone got the intervention eventually, but to treatment and control arms, which included like if you were a man who was randomized to the control arm, you were supposed to go to the control facilities. But what happened was, we did the intervention in the intervention facilities, and the group intervention happened, and the group intervention happened. And of course, the men are all talking to each other. So basically, we had no difference between the treatment and the control arm in HIV testing, because all of the men in the control arm went to our intervention facilities for testing. So that what you're explaining is like, yes, the men who were part of the intervention were like, hey, there are actually facilities you can go to where you'll be treated respectfully. So, let's all go together. So yeah, I think that's really important. And some of the places I've worked, it's actually been a much more formal peer, sort of actually peers that are then become part of the health facilities. So and that's also very good for stigma reduction, because the peers become part of the health facility. And so they're interacting with staff on a daily basis and breaking that down. So, and that example I gave from the sex worker collective in India, that actually happened. And so that really, really helped to break down stigma also in the health facility, because they were now members of the staff.
Great. We are just a few minutes past the hour, so we need to wrap up. Thank you for your input there, Peaches. Let us all thank Laura for an excellent session. There's lots of love in the chat for you, Laura.
Thank you.
Terrific. Great. Thank you all for coming to this, and we'll have another session in June about our universal precautions approach to reducing stigma. So thank you, everybody. Have a lovely day or evening wherever you are, and we'll catch you next time. Thanks again, Laura. Fantastic job.
Okay. Bye. Have a good day, everyone.